学习，多好，都没有跟你收钱啊。Okay, so this is the urine from an 82-year-old. He received ureteroscope, and the clinician found out that in the left ureter there is a tumor. So this is the washing cytology for left ureter. So because it is a washing cytology, we know it is very common that we will see cohesive larger fragment of urothelial cell. So this type of specimen doesn't just because of you see large fragment, and it is problematic because you still need to go to the higher power to check the detail of the cytomorphology. So because it is a washing cytology and it is a urinary tract washing cytology, so it is common that you can see benign urothelial fragment with a nice umbrella cell at the periphery, at the same time with the high-grade urothelial carcinoma. So for the high-grade urothelial carcinoma, we usually rely largely on the increase of NC ratio. So if you see in the background, there will cry some single cell with markedly increase of NC ratio. The chromatin pattern, however, is more hypochromatic instead of the hyperchromasia cause chromatin that we were familiar with. So around, I would say, almost 20% of the cases, you will see this hypochromatic chromatin pattern. However, the nuclear contour is still irregular. You see the nucleus is not rounded, they elongated, angulated. There are some notch around the membrane, so this is positive for urothelial carcinoma. And because the clinician already see there is a tumor in the ureter, so it is also compatible with clinical observation. So in the background, we see a lot of these single cell compatible with high-grade urothelial carcinoma. But most of the larger fragments are actually benign urothelial. So the second specimen is a CSF cytology. The patient had the past history of lung adenocarcinoma, and she was suspected to have leptomeningeus metastasis. For CSF specimen, the cellularity is usually very, very scant. So you really need to be careful to check if there is any cells in this specimen. So on just the first glance, you may think that the cell is relatively bland looking with a finely smooth nuclear border, and the nucleus is perfectly rounded. However, we realize that the majority of the time in the metastatic adenocarcinoma in the CSF specimen, the cell can present with the very bland looking cytomorphologic feature. In this cluster, you see there is a vacuole in the cytoplasm pushing the nucleus to the periphery of the cell. So this is compatible with metastatic adenocarcinoma. Most of the time, when you see the CSF specimen, I would say the loose stain, the dry smear loose stain would be the best staining for the CSF, because the cell, the size of the cell is usually exaggerated. So again, on 40X, you see these very large, very big cells, and with plenty cytoplasm. So this is compatible with adenocarcinoma metastasis from the lung primary. The next specimen is from an ascites specimen. This specimen is relatively challenging She is the patient of 89-year-old female who had a past history of hepatocellular carcinoma and underwent multiple like a TACE. In this current presentation, she had shock and was suspected to have HCC rupture. HCC we rarely see in the body fluid specimen. In this specimen, we see a lot of cell cluster, mostly in three-dimensional architecture, arranging in a cell ball, like a pattern. When you go to the higher power, the cell has relatively abundant cytoplasm. Within the cluster, there is a little bit polymorphism. However, you do not see a striking nuclear atypia. So when you check the clinical information, the patient do have cirrhosis. The HCC is related to the cirrhosis, and she is now currently the child B to child C status. So if the patient had a liver cirrhosis, usually the liver surface would be very like irregular. And through your breathing, through your body movement, the irregular surface can induce the reactive changes of the mesothelial lining in the peritoneum or in the visceral. So sometimes in severe cirrhosis patient, you will see the ascites presented with these multiple cell cluster. And it is uncertain if this is carcinoma. I would say I would favor this is likely reactive mesothelial cell instead of carcinoma, especially that we know the patient had hepatocellular carcinoma, but it doesn't look like a hepatocellular carcinoma. So it was sent out as positive carcinoma, but we really need to do some ancillary tests to confirm. So first of all, I want to confirm if these cells in the cluster are mesothelial origin. So we can do a creatinine. And because she's an elder female, the overall morphology may be an adenocarcinoma. So we would do a MOC31, and then we can do a arginine 1. It is the patient doesn't have a cell block preparation, so I guess we can only use the cytospin. So we would check. So I personally think this is most likely to be reactive mesothelial cell, but in a cell ball pattern, which is relatively unusual. You will mostly see this in a mesothelioma. However, one exception is if the patient had liver cirrhosis. So the next specimen is a pleural effusion specimen from a patient with history of lung cancer. In the pap smear, there's no like a typical cell, but in the loose stent, there are two clusters of these typical cell with vacuolated cytoplasm. So this is suspicious for adenocarcinoma. There is a cell block, but we didn't see any like a typical cell there. So overall, I think it is suspicious, but not definite for adenocarcinoma. The next specimen is also a ascites specimen from a 49-year-old female with a past history of gastric cancer. So we see really scant cells and with relatively low-grade nuclear feature. However, you see there is a mucin vacuole in the cytoplasm. So you know this is mucinous adenocarcinoma, likely with a signaling ring cell feature. So this is metastatic adeno and compatible with the past history of gastric adenocarcinoma. So let's move to EUS guided fine needle aspiration. So we have 2 pancreas cancer today. So for the EUS, it is common that you will sample some benign intestinal mucosa. And so you can see there is a goblet cell over here. If you adjust the focus, and you can see the mucin vacuole on top of the nuclear. So this is coming from duodenum. Right next to it, you find a cluster of highly overlapping cells and with marked hyperchromatic chromatin pattern. So this is definitely different from the benign cluster. So this is adenocarcinoma. So if we can find some cluster, it's more easy to appreciate like this one. So you can see there were a couple abrupt mucin differentiation with vacuolating cytoplasm over here. So this is positive for adenocarcinoma. And the contrast is very obvious comparing to the adjacent normal mucosa. So the next specimen, in the background you see a lot of mucin. So these findings not normal. It's usually in the mucin producing epithelial tumor. It can be IPMN, or it can be IPMN associated with adenocarcinoma. So then you go to the cell component. Here is definitely adenocarcinoma. You see disorganization, and you see nuclear polymorphism 1 to 4, and this is adenocarcinoma. So we do have a couple, like a more high-grade cancer cell in this specimen. So here again, very disorganized, a lot of like a bubbly cytoplasm, and the nuclear is definitely atypical. So this is also positive for adenocarcinoma. Next is a relatively uncommon and unusual specimen coming from a 56-year-old male with a parotid mass. The clinicians say it is 15 centimeter. It is a very large, very big parotid mass, 15 公分. So this is the liquid-based preparation, and we see a lot of cellular fragment. The cell has this like oval to spindle morphology in tight cohesive cluster. And the nuclear show vesicular nuclear chromatin pattern, and quite often you can see irregular nucleolus. So this looks like a carcinoma, but with a little bit of spindling, we would usually think about, could it be a myoepithelial cell origin, or could it be a ductal epithelial origin with this spindle morphology? So because of this high cellularity, we decide to do a cell block preparation just for further ancillary testing. So let's take a look at the direct smear first. So for the direct smear, again, we see large chunk of overlapping cellular fragment, and the nuclear tibia is obvious. There are quite some naked nuclear in adjacent. So it is likely a myoepithelial tumor, but we cannot exclude if it has some ductal differentiation as well. So we do a cell block preparation, and we have a very tiny, like a cluster of specimen. And so you can see, again, the cytomorphology is very similar. We only see solid sheets of these cellular fragments. And the nuclear atypia is obvious. And it is very common that we can see some mitosis in these cell fragments. So it definitely looks malignant. So first of all, we want to demonstrate the differentiation of the cell. So our first consideration is if it is a carcinoma, so CK is positive. If it is a ductal epithelium or myoepithelial element, so GATA3 for ductal, it is only focally positive, mostly negative. The P40 for myoepithelial cells, it is strongly positive. However, P40 can also serve as a squamous marker, so we need to pay attention to that. So we also do some myoepithelial marker. This is actin. So actin is also positive. So it is likely a myoepithelial carcinoma. So our final diagnosis is Milan, category 6, malignant. It is a carcinoma high grade and compatible with myoepithelial carcinoma. So next we have a couple thyroid fine needle aspiration. This is a liquid-based preparation. On low power, we don't see any colloid. We see some cellular fragment, and when we go to high power, the cell is composed most exclusively of oncocyte, of Hurso cell. So in the background of no colloid and with a cellular aspirate composed of mostly or exclusive Hurso cell, the diagnosis is TBS4, suspicious for oncocytic tumor. So this is one of the case. The second case with a very similar finding that in the background we didn't see a lot of colloid, we only see a few thick colloid. In addition, we also see a lot of very, very tight, small cellular cluster composed of follicular cells with slightly enlarged of nucleus, but without any features of papillary thyroid carcinoma. So we have aspirate with mostly microfollicle of slightly enlarged of follicular cells. And the background there is very, very scant colloid. So the specimen is compatible with TBS4, suspicious for follicular neoplasm. So again, a different specimen. We see very scant colloid in the background, and we see a lot of these small, tight cluster of microfollicle. So this is also a case suspicious for follicular neoplasm. So we have 3 follicular tumors today. 2 of them were usual type, and 1 of them were Hurso cell, oncocytic type. So finally, this is a pap smear. This is a relatively young patient who had a past history of condyloma. Condyloma is considered equivalent to a loceal in pathology classification. So here in this specimen, we only see one single cells with at least collocytic change and binucleation, but very small nucleus. So because there's only one of these, we decided to call it ascus. If the patient had condyloma, it should be grossly visible. So the clinician already know that she had a condyloma, can treat it. And usually the condyloma is arising from major labia or in the vagina. It is not very common in the cervix. So it might probably coming from the vaginal tract or the outer external genitalia. But there's only one cell, so we call it ascus. Okay? So let's see for today. Yes.
Have you read the one I sent you for the methodology?
I haven't.
I
I would read. Okay.